this week on the BackTable podcast.
And when you become really competent at doing it, and then you're able to do it kind of almost by feel, then you're next level. We're at the point where we're doing it without adequate guidance, and we're trying to do it by karma, vibes, and good feeling. What we need to do is take that skill and that capability and ratchet that up as much as we can. We need to use not only technology, but we need to use that ability in conjunction with that technology to advance to the next level. And that's kind of what we're looking for now. There's nothing more impressive than somebody that's operating that has really well-developed visual spatial skills that is able to have a ultra minimally invasive, more percutaneous way of doing big things on the inside, little poke holes on the outside.
Hello, everyone, and welcome to the BackTable MSK podcast, your source for all things musculoskeletal. You can find all previous episodes of our show on Spotify, Apple Podcasts, and on BackTable.com. First, a brief message from our sponsor. RADPAD was developed by physicians for physicians, clinically proven radiation protection during cine and digital subtraction angiography. Don't bet your career or your health on anything less. Trust RADPAD radiation protection shields for all your fluoro-guided interventions. See radpad.com for more information and contact info@radpad.com for a free radiation evaluation and a no-brainer radiation protection cap. And don't forget to tell them that you heard about it on the BackTable podcast. Now, back to the show. This is your host, Jacob Fleming. Welcome back to our final part in the series on osteoporosis and treatment of vertebral compression fractures with Dr. Beall. You know, when we talk about pushing things to the next level, this brings me to something else I wanted to talk about, which is insufficiency fractures outside the vertebral body. And I know you've done treatments of these at a lot of different places in the body. So can you just, to this day, you're the only person I've seen share a case of pelvic fracture cementoplasty outside of ablation and stabilization for METs, which is another procedure that I've been really excited to see gaining popularity, but there's kind of different considerations there than a fractured osteoporotic pelvis. So can you just talk to us about that, and how do you approach doing these cases, pubic ramoplasty that may not necessarily have any kind of how-to guide other than maybe the one you've written?
Yeah, no, right, exactly. One of the things that all of these have in common is I wrote a paper previously that had 60 plus fragility fractures of the pelvis. Most of them were sacral. So I also had some pubic rami, inferior and superior, acetabulum insufficiency fractures, iliac wing, and all of these. The only thing the fractures had in common is that all of them I treated for free. Because there's no way to bill and code. It's an unlisted code for all of these. But one of the things that we've seen is the ability to get somebody up and around is pretty profound with the treatment of the pubic ramus, the acetabulum, anything, tibia, calcaneus. I mean, there's fractures all over, including clavicle and ribs that we can do. Now that we have the capability of guiding screw placement, and the ability not only to use film material that is cement, acrylic based, but we have film material that's ceramic, hydroxyapatite calcium sulfate. We have struvite. We've got film material that is biologic. We can pack it with cortical cancellous chips. We've got strings of DBM. So we have lots of different things that we can use. And one of the things that I like to do recently is combine, rebar and cement, a film material and a metal, usually a screw, type of screw, to fix fractures. And I've done sacroplasties like this. I've done combination. A recent case I've done is an SI joint fusion, somebody that has an L2 to the sacrum fusion that has had a lot of iliac bone graft harvest sites. Now his bilateral SI pain has undergone a previous SI joint fusion that was ended up in a pseudoarthrosis, and now has very little left of the ilium, including some parts of the ilium adjacent to the joint. and yet she has bilateral SI pain. And so I put 3 screws in, 11.5 by 50, 11.5 by 60, 11.5 by 50 screws across the joint, and then cemented those in. So the rebar and cement combination. And that's basically the only way. We had to kind of recreate that bony anatomy that was removed, that was additionally put at risk because of the pseudoarthrosis of the attempted bony SI fusion. So if you use these principles that we talk about, and to use the principles, I'm going to borrow from another specialty, the AO principles of fusion, and to accomplish the realignment, to accomplish the stabilization, to preserve the blood supply. The AO principles of fracture fixation. You can get pretty good at fixing fractures outside of the normal locations. And, this is how we initially established in the vertebral body. We wanted to do something other than transpedicular to be able to put big things into the vertebral body. So that's where the original descriptions of the parapedicular and the inferior plate extrapedicular approaches came from. And to do things as from a radiologic background under CT, we can do CT guidance, and we can establish the approaches under CT guidance. We know it's safe because we can see the surrounding structures that are there, avoid them, and avoid potential complications by seeing the structures that might be injured from the procedure we're doing. And then we take that, because it takes too long to do under CT, at least in my hands, then I do it all under fluoro. And we understand, we adapt that to do it under fluoro. It's fast. You can understand the anatomy. You can recognize where everything is going. And then pretty soon you're able to combine hardware plus any type of film material in a complex 3-dimensional way, especially around something that's hard to treat like the pelvis. But if you have the anatomy of pelvic anatomy and you know what to look for, it becomes quite a bit easier. So I think, the ability, we should expand and use our native understanding of the anatomy, our native ability to guide things with imaging modalities other than fluoroscopy. And we should be able to think in our visual spatial channel, our inner visual spatial adeptness, to be able to create something that we can do under fluoro that we invented under CT. And all of these are just different ways of looking at the body. And I think challenging ourselves to be able to do this in a way, one of the things I've not really understood why we're not doing, I don't understand why we don't have the greater capability of doing things in a 3-dimensional way, because we can isolate a person's anatomy to the pixel and voxel within the body. I don't understand why we don't have a better way to target and to look inside. And I would like to have a combination fluoro and CT, not the current way that we have it, but a better way to use it. I don't like some of the crude tools that we have. Having said that, I do most of my work with just very simple tools. I have fluoro, and until recently, I just had CT without CT fluoro. So I think you can do great work. I think there needs to be advancements to be able to improve the work that we do in the suite, to be able to take a good look at it. Cone beam CT has been great. Some of the combination O-arm, the CT fluoro thing has been okay. I think it needs to be improved quite a bit. But these are something that will expand our capability to treat, to put exactly what we want to do in exactly the right spot with 100% certainty. And until we get there, we're not there. And that's the direction. That is our point B, though.
That's just great. I really like what you said about improving what we can actually do using the imaging capabilities. That's what we do as radiologists. And I think one of the things that sets us apart from other specialties, there are some other specialties who will use CT. I mean, CT, not live CT, but CT navigation has been used in neurosurgery for eons now. And so we are starting to see, approaching what you're talking about with integrated angio CT units. I think that's going to be something that really drives us forward. But I really did want to bring up, and I'm glad you emphasized this a little bit, that you're doing most, if not all, these cases under, and I wrote down the quote that I heard you say before: marginally competent C-arm and good karma and vibes on tap. So Can you just tell us a little bit about your C-arm? Does it have a name? And just how do you manage doing these complex procedures with pretty lean equipment?
Yeah, I've got a C-arm that has tape holding parts of it together, and I'm not kidding. And it is marginally competent C-arm. And we came out of a case the other day with the case I described that we were doing the screws combined with the sacroplasty, and it wasn't just, it was an iliumplasty, osteoplasty, the ilium, the sacrum, inside the SI joint, around those three big screws. And my fellow said, well, how'd you do that? Because we really couldn't see what we were doing. And I couldn't really explain to him how I was able to do it because I really couldn't see it. I mean, I just, you use the force. I don't know. You just kind of by experience, and certain things to look for, and you just do it by feel and combination. And really what I want to get to I want to get to a point where the imaging that I have access to makes me better. I want to have the ability where the imaging that I'm using does what I want it to do, rather than for the imaging to allow me to do what I see as possible. I want, instead of it allowing me like a CT visualization to do what I think is possible by seeing that on CT, I want to have the capability of doing complex things and having the imaging allow me the capability of taking that just one step further. An example of this is whenever you put big screws in, the artifact from that is fairly profound. And sometimes I can't tell the wall of the neural foramen versus an artifact. So one of the things I'd like to have the imaging capability to be able to allow me to go right up to the border of something I need, maybe even access that cortical wall on the other side without disturbing the neurological components that's underneath it. And that's really, we're not quite there yet. And one of these things about having the visual spatial skills that radiologists have, and to be able to extrapolate that over multiple modalities is incredibly helpful. And once you get to the point where you have an understanding of the anatomy, so that you can kind of do things without even observing them directly, and that sounds like something that's crazy, but you kind of know what to look for, and you're able to extrapolate your experience with cross-sectional imaging versus planar imaging, and can do so repeatedly at a very high rate of safety, low rate of complications. This is something that I think whenever we get to a combination of, you mentioned CT and angio, that's, fantastic advancement. I always thought we would be at the point now where we could have guidance to a certain point within the body on almost a real-time scenario. An example of this would be, why can we not have robotic guidance that helps us out and facilitates and makes the access to a certain point within the body on a combination CT fluoro unit that we've identified, here's the point where we need to get to. Mm-hmm. And it may be a circuitous route to get to there, but as long as you have the capability of identifying a specific group of voxels within the body, why can't we figure out a way to get there that may be even a nonlinear rate? And why can't we just make this faster so we can get in and do what we need to be doing, just automate that? So this is kind of what I'm talking about, the imaging making you better. But right now, I think we work with the tools that we have. And one of the things, after having done hundreds of courses under fluoro and taught things that way, there are very few, if anybody, that's better than an interventional radiologist at really guiding things. You can always spot one as opposed to some of the other specialties. And this is something that people don't give themselves enough credit for. And this is our formative years were spent under fluoro, guiding things to get to a certain place. And that is not lost later on in life, because just because everybody that you work with is pretty awesome in a visual spatial sense doesn't mean that's any less impressive of a talent. It just means that the other people you're working with are probably just like you, the same level of competence.
Absolutely. I think it's something that is easy to take for granted in radiology training, especially for my peers or people a little younger than me, we know we want to do IR. We like imaging, but when you're on a diagnostic service, which is most of the time in the early years, you're maybe kind of daydreaming about the other side. But something I experienced just a few months ago, and I'm kind of into the latter half of my diagnostic residency, is that something just switched imperceptibly. And as I was reading CTs, I found that my mind was creating a 3D topography of what I was looking at. Whereas before that, for years, you're just like, okay, this is the picture at this level. You're kind of going through slices, just like, slices of a bread loaf, without at some point, and maybe it's very possible that I'm slow on this and everyone else hits it in their first year, but it took me a few years to that visual spatial sense really integrates it, and you're no longer consciously requiring it. It's subconscious, and you're just noticing things. And I would imagine that has a lot to do with how you're able to do such a complex approach under fluoro. You're integrating what you're seeing on the imaging, your tactile sense, and just the tens of thousands of cases you've read and seen before. That all kind of comes together, and it's almost automatic.
So I was listening to a podcast, and it was somebody about one of the scientists who went to visit a tribe that had a really unique language. And the language is kind of directional based. And there's lots of languages that are based on lots of different things, but this language was kind of directionally based. And this was a nomadic tribe, and they kind of would greet each other. Something you would come up to me and I would say, you would ask how I was doing, and I would say, I'm doing fine. I'm heading north by northwest. And it was a really directional and location based language. And so the scientist who was there and observed it and was there with the translator and was able to hear and communicate with the people, and was there for a fairly extended period of time. And then one day she was there and she described the event, and she was talking to somebody, and then suddenly, based on the language and based on the discussion, she saw in her mind, a little panel appear and saw herself like a map, and saw herself as a red dot or a dot in relationship to the rest of the map. Pretty excited, and went back and described to one of the elders of the tribe, I see this map, and now I understand how to do this. I understand where I am, and I understand how to greet and talk with people because I see myself on the map. And the elder said, well, of course, how else would you do it?
Mm-hmm. That's fascinating.
So it's about developing the visual spatial skills to the point where you're able to combine the visual with the spatial. And if people think evolution happens like this, it doesn't happen like this. Evolution happens, fits and starts, right? Sudden kind of, and the evolution to have great visual spatial skills happens like regular evolution, and fits and starts. One day the switch is off, next day the switch is on. You have the ability to do this. And a lot of what we see is spatial, the ability to hit a tennis ball, shoot a basketball. And this is kind of the spatial orientation, the spatial awareness. To play cornhole and be good at it, that's the spatial awareness. The visual is something that also requires practice, and people don't understand it. There's Nobel Prize work by Hubel and Wiesel in the 70s, and this is about visual spatial type of awareness, and primarily the visual. So the visual cortex is in back, it's connected to the neocortex in front, and the medial prefrontal cortex, which is kind of your judgment center. And that's why this is so important, is a connection between the neocortex and the visual cortex. And they raised kittens in horizontal lines, and all their immediate existence shortly after birth were raised in an environment that had all horizontal lines, no vertical. So they let them out into the office space, into a normal environment. And what do you think happened? Well, the kittens ran into a desk leg, a chair leg, side of a door, anything that was vertically oriented. And how many times do you think that happened? Well, once, right? And the kitten was like, okay, don't do that.
Yeah.
That's, I can see it now. And so they repeated the experiment, and vertical lines Same thing happened, except they couldn't see. So were those kittens, were the cats blinded, literally blinded to horizontal or vertical lines? The answer is of course not. Of course not. They were not blinded to it. They just had never seen it before.
Mm-hmm.
And one of the things that whenever we used to have plain films and we'd see something, even now, we'd see it on a monitor, we'd see a hardware with a broken screw there with a resident or a fellow that never really seen that before. So what do you see there? Oh, I don't know. Yeah, I don't know. And to me, it's obvious. And then, I used to, in the drawer, I have screws and I have a couple that are broken. So I take them out and I put them on the desktop. So what do you see now? I see a broken screw. I said, look back at it. Okay, broken screw. So the old adage, you see what you look for and you look for what you know, is based out of the work of Hubel and Weasel. And it's based on the connection between what you know, because if you've never seen it before, you can be literally and figuratively blinded to that. And of course, you're not literally blinded to it in a real sense. I mean, your eyes are working, your visual cortex is working, but unless you're able to put that and benchmark it as to what this is and understand kind of where this goes in your knowledge base, you won't be able to see it. And so that's how people develop their visual spatial skills in 3-dimensional, and suddenly you can see, right? You take the red pill. You're able to finally, you look at enough of these things and you're able to get the knowledge base of how the liver is shaped and the bones are shaped and the spinal canal. And then it hits you all at once. Okay, I've got it. And to developing this to access it from the outside, that's the next level. And when you become really competent at doing it, and then you're able to do it kind of almost by feel, then you're next level. And that's what we need to do, is take that skill and that capability and ratchet that up as much as we can. We need to use not only technology, but we need to use that ability in conjunction with that technology. Then I think when we're at the point where the tech actually starts to make us better, we're at the point where we're doing it without adequate guidance, and we're trying to do it by karma, vibes, and good feeling. And what we need to do to go to the next level we don't have. I think that's what we need to do to combine, to take the tech with the ability to get everything to advance to the next level. And that's kind of what we're looking for now. There's nothing more impressive than somebody that's operating, that has really well-developed visual spatial skills, that is able to have a ultra minimally invasive or percutaneous way of doing big things on the inside, little poke holes in the outside.
Absolutely. Could not agree more. I think, again, preaching to the choir, given our audience, but I think that interventional radiologists, and I'd include, interventional neuroradiologists and musculoskeletal radiologists in there. I think we're really the ones that are going to be pushing the field of interventional spine. And I see this, a lot of the stuff coming out of Europe, I think is maybe a couple steps ahead of us, predominantly probably due to FDA kind of stuff, but some of the work from people like Luigi Manfrey showing how to use this multimodality integration. That's just the future for us. And I'm really excited to see what's going to be happening in the next few years. And on that note, we've had great discussion about osteoporosis, medical, diagnostic, and interventional. There are a couple other topics I wanted to talk about. And so the first, from what we're talking about, the bleeding edge of musculoskeletal IR, what stuff is on the horizon? You've talked about a few things, but what are, 2 or 3 things that are really exciting to you right now?
So one of the things that's really, truly novel is disc augmentation. So, and this is for fans of vertebral augmentation, you'll find this really easy to understand. Intradiscal augmentation with hydrogels. So the gel that a couple of weeks ago, I was up in Calgary, Canada, and Alberta. We were doing intradiscal augmentations. I was doing it with my former fellow Olivier Clerc, and it was great to see him work. It's absolute stud and really adept at what he does, and I was very proud. And to be able to combine a disc access to be able to augment a disc. And this stuff is a combination of PVA, PEG, and PVP, polyvinyl peroxidone. And it goes in as a liquid, and it cools, and it goes in maybe about toothpaste consistency and cools to a gel that has about the same tactile resistance as maybe a medium hard eraser. So this is like fix-it-flat for a disc. And the ability to, and it's a polyvinyl alcohol, polyvinyl peroxidone, and that polyethylene glycol makes it to be able to go in as a liquid and harden. And this stuff, it attaches to itself by hydrogen bonds. So and it tends to meld together. So if you have it together, you're able to break it apart, say in a testing environment, and you leave it just in a repetitive stress machine, and you come back, the gel will actually meld back together, self-healing hydrogel. So it heals with hydrogen bonds. So as long as it's not as long as it is in an aqueous environment, it will heal back together. So this is the kind of stuff that in at least the early feasibility studies in Colombia, and the pivotal trial will be done here. The pilot trial is done in Canada. The early data on this stuff looks fantastic for treating back pain. And it's not regenerative. It's not ablative. It's an augmentation. So it works in the annulus, it works in the nucleus, and it looks to be something completely novel and completely different. So that's one thing. Another thing is we have the capability now of doing interspinous process devices. The first one out of the box was X-Top, and the downside was the 8 or 9 centimeter incision necessary to put it in. We've modified that to Vertiflex. We've kind of have a fusion spacer, and there's a minimally invasive fusion spacer called the Minuteman. It comes from Spinal Simplicity. The ability to do this really emphasizes the need for us to do more in terms of the ability to have a 3-column approach, simply because I want you to vision this scenario: 75-year-old female with grade 1 to 2 spondylostenosis, 4, 5, 6, 7, 8 comorbidities, not a surgical candidate, but has very significant stenosis to the point where legs are starting getting weak. So once that happens, once the legs start to get weak, you got to have about 6 months before that becomes a permanent event, before you can decompress and the patient doesn't get better. That's kind of an average type of rule. So non-surgical candidate, legs starting getting weak, grade 1 to 2 spondylostenosis. How are you going to fix it? I mean, is it fixable? The answer is yes, it's fixable. How do we do it now? We do a spacer, and we know that spacer is not enough, it's sufficient enough, even if it fuses, to hold up over time. So we need some anterior column support. The reason why the person has a grade 1 to 2 spondy is because the disc is dust. So if you're in grade 8, and the scale only goes to 8, I mean, there's nothing there. We need the ability to pull it back. And can we pull it back? The answer is, of course, yes. We need to do it through Camden's safe triangle. And we can do the ability to have expandable implants, and we could pull that back, and an implant that goes from back to front, starting like this, makes a lot of sense to be able to reduce that spondy. You can do it also with ligamentotaxis, and then the ability to fixate, to provide a long-term fusion there. But why would you want to do a fusion to say treat that 75-year-old the same way you treat a 40-year-old in terms of bony fusion for spinal listhesis? I mean, that doesn't seem to really make much sense. Make her 85, and that even emphasizes that point more. So the ability to have instantaneous fusion, I mean, you could put bone cement in there. I don't say anything wrong with that, but that's not typically done. But I want you to imagine the ability to do 2 implants that are expandable up to about 16, 17 millimeters, a little bit of lordosis, to be able to reduce that grade 1 to 2 back to negligible, or grade 1 half, to put a fusion spacer that will fuse at a rate of 96, 97% based on our recent data, and have the ability to put an adhesive or cement or something that will grow into bone, that will design to stay there a long period of time. You could fix her with 3 incisions the biggest incision would be 2.5 centimeters, and do so as an outpatient to have durability that would be maximal on and a tremendous amount of of symptom relief in somebody that has been called a non-surgical candidate who his clock started ticking on the leg weakness. So all of these components of everything around there are now present. It's just a matter of assembling this together to be able to do something that's effective. This is what one of the things I'm working on now is the ability to assemble these things together and do so in a standard way to give people the ability to provide a tremendous amount of symptom relief, because spinal stenosis and stenosis are two things that produce symptoms that once you treat, people get better, and they get better predictably and durably. And it ranks right up there. The stenosis relief does with oh my God, thank you very much. It ranks up there with vertebral augmentation in terms of patient satisfaction and outcome. So, that's another thing. There's more. I'll kind of stop right there.
These are too much.
These are things that are exciting, but this is, not only within reach, a lot of these techniques I'm referring to have been around for a while.
Mm-hmm.
It just takes the technology that we put in for patient correction to catch up. It takes a while for that to catch up with our ability to do the certain approaches.
Yeah, I agree that the concept is really exciting. This anterior and posterior fusion through percutaneous means. I think it's a high time that kind of these large pedicle screw constructs, especially for simple spondy, I would like to see those be a thing of the past, because you have patients, even if they get better from the spondy perspective. You've talked about the data on the recovery from those kind of procedures. And this is not to knock on spine surgeons at all, because they're doing fantastic work. But I see this not infrequently that, we see something called minimally invasive. And then we see kind of the intraoperative imaging. It's like, you compare that to the stuff we're doing in IR, which is mostly almost entirely percutaneous. I think, minimally, it's all relative. And I would say that if, that minimally invasive spine surgery, that's part of the parlance. I think that we need to use the term that you used a few minutes ago, which is ultra minimally invasive, or what I've seen Dr. Manfrey from Italy refer to as covert surgery. I think that's probably the coolest way of thinking about it, and very accurate too. So all that stuff you're talking about is really exciting. Can we expect to see some data on an approach like this anterior posterior fusion you're talking about, or is this kind of more in the just kind of early phase?
We'll see some data within the next couple of years. So this will absolutely be described and posted and data collected about the outcomes of this, because we know the outcomes are great. If you were to take an 85-year-old woman and do a decompression fusion, the outcomes would be really good. It's about the adjacent segment disease, right. And that's why we don't do it quickly. But in a scenario like this, you really have to, and you have to provide stabilization for spinal listhesis. It's just about minifying that. Mm-hmm. It's about limiting the surgical risk and about accomplishing the same goal, just not doing the same amount of invasion that hurts the patient, especially when they have comorbidities, or they're frail, or they're elderly, or some other risk factors. And, the ability to do a lot of these things that will provide tremendous amounts of pain and functional improvement in people that are traditionally thought of as non-surgical candidates. We have to keep in mind that just not so long ago, we were collecting registry data on joint arthroplasty because, that's just joint pain. That's fine. They're just going to hurt. The joint replacement is expensive, and they could just, take some aspirin. Right.
Right.
And we had to kind of make the switch in my mind to switch that gear to the point where we were saying, it's in the techniques now with the robotic assisted surgery, minimally invasive anterior hip approach, and things like this. And these are the type of changing gears to be able to get into the point where, yes, we know we need to accomplish. A lot of this is treatment has time-honored tradition and a proof that what we're doing, correcting this pathologic entity, works. Now we need to be able to minify it. Now we need to be able to use different tools. We able to use a different approach to accomplish the same thing in a much less invasive way. And, I think the future's exceedingly bright for a lot of these techniques.
Absolutely. And I can't wait to see what we're going to have in 5 years. Just from 2 years ago or so, spine jack was just kind of coming onto the scene, at least over here in the US. And now it's quite popular. I think we're seeing, great success with that. And I'm really excited to see some of the new technologies that are being solidified. And more than that, I'm really excited to see our specialties increased involvement in this area. And it's not anything about, chest beating, we're the best or anything, but for the reasons we discussed a minute ago, our skill set is so well suited to these problems. And you discussed multiple times the patient who's not a surgical candidate. They have no option. That's where we live. That's where we're raised as IRs in residency, even, is doing something for a patient that nobody else can do. And, we're used to doing that and frankly, kind of a fatal and kind of Hail Mary sort of process. And I think what is so gratifying about this area, what made me gravitate toward it, and the reason I'm seeing a lot of my peers interested in it as well, is you're moving away from that kind of fatalistic, let's just do a Hail Mary kind of thing, toward something that is really increasing that patient's long-term outcome. You're getting them up and about, and that's obviously typified in your approach to osteoporosis. And I think it applies to so much else in the musculoskeletal system. So I'm just really excited to see what's going to be coming out in the next few years.
Amen. When you consider things like interspinous process device and the kind of ubiquitous use by vertebral nerve ablation, regenerative treatment for the disc, hydrogel, all of this stuff is new within the past 5 years. And so I can't imagine the next 5 years, how exciting that'll be.
Absolutely. There's one more topic I want to touch on before we finish, and this is about your newest book. And this is not about a new technology, but it's a fantastic one, and one that I think IRs are pretty not well aware of. And so last time you were on the show, you had recently published the excellent textbook Vertebral Augmentation, which we discussed a few times in the show. That's just an invaluable resource for anyone treating VCFs, and I'd recommend it. And so now you've recently put out the new textbook, Intrathecal Pump Drug Delivery, published by Springer. And so I've noticed you're one of just a handful. I can't actually think of another example, but one of very few, I'm sure, interventional radiologists out there putting in intrathecal pumps. I know it's a topic you're very passionate about. And eventually I think we need to have just an entire episode dedicated to this topic. But for now, can you tell us a little bit about the new book and why more IRs should be learning the art of intrathecal therapy?
So the new book is right here, right there, Intrathecal Pump Drug Delivery. And, I wrote it because there isn't another one. So there's no guide to this. This has been around since the 80s, the intrathecal targeted drug delivery, and it's very powerful. And I've never really understood, to kind of hone this in on interventional radiologists at the outset. I've never understood why this isn't in everybody's wheelhouse. I've never understood it at all. Let's take something as easy as cancer. So cancer and cancer-related pain. So we do the diagnosis. We see there's a mass. We do the biopsy. The pathology comes back malignant, and we do lots of different interventional oncologic treatments. We do embolization tastes. We do cryo. Lots of different types of therapies. We follow along with the distal imaging. We put ports in people, and we do all kinds of maintenance over time. These are patients that commonly are affected with pain. But the king of everything for pain relief, the intrathecal pump, we don't do. And it's just nothing more than a big port. This is something that goes in. It's a 20 or 40 cc pump, and it's accessed in the center and has a catheter access point on the side. You put it and you access the pump to do things with the catheter and refill it through a port, just like a big port. Mm-hmm. And it's for patients that have metastatic disease, especially in patients with pancreatic cancer. These two are more notable for having an increased amount of pain. This is about the only thing you can do to give them adequate relief of pain. And, based on the intrathecal system, the blood-brain barrier and everything else, the medications you put in the CSF puts the pain medication right next to the pain receptor. And it's done so at a dose between 1 and 100, 1 to 300 less of a dose intrathecally than you take orally or systemically through a patch or any other route that's available. So it does far better for pain than anything we have. It's on the continuum of cancer care treatment, and it involves a huge number of people that have continued ongoing moderate to severe or severe pain, but we just don't do it. And I think a lot of it is due to lack of familiarity. So one of the things that I noticed not until later was there's two companies that make the pumps, Flonix and Medtronic. And, I was the first interventional radiologist to do a pump with both companies, I think. And they just don't look at IR as a typical customer.
Mm-hmm.
And consequently, they never really pay attention to you. And that's, to me, a little bit incidental. Don't really care too much about that, but they do, the company provides good support in terms of representative coverage and it's been very successful. And it comes down to the point where I think there's not a how-to manual on this. So people talk about medications you can use, what kind can you use, what concentrations, how to use it, how do you do a trial, how do you do the implantation, what tools do you need? And so I got to the point where I wanted all this to be written down so I could pass a book on to somebody to say, here, this is why you should do it. I mean, it's pretty easy when you see the sequence. I mean, you cover everything in relation to cancer pain, except for the most obvious, best thing that you can do for cancer pain. And all it is a matter, you put in ports, you put in this is like a big port. So why in the world wouldn't you do that? And for severe spasticity, for multi-site pain, for chronic and severe pain, this is basically the only thing that you can do, especially in patients that are non-surgical candidates. So for me, this is an absolutely essential part of my practice. I mean, I can't imagine not having access to it because we use it and people, this is a back of the rack solution. This is better than anything we have for pain. And in those 5 categories that I mentioned, that I listed off, is basically the only thing that we have. So this is kind of a how-to guide. It's something that I think IRs are very, very well adapted to doing. I think that this is something that they just have not been exposed to because it typically doesn't fall under the typical customer base of the companies that make and sell the pumps, and that try to do training courses and really engage the societies from that level to the point where they encourage you to do pumps. And if you've never been exposed to anything like this, how would you know?
Right.
And I kind of was exposed to it and started doing it just based on need. I mean, I for cancer pain, for severe pain, for multi-site pain, I mean, there's nothing else. I was doing the full spectrum of interventional pain management, and I had people that I couldn't treat, and started looking around. And I remember this a little bit from residency, and I think I probably need to start doing pumps, and we did. So, and it's been very gratifying. I mean, I was considering it, and the way that this started was we had 2 of our individuals that were managing 67 intrathecal baclofen pumps for spasticity, moving to be a hospitalist and retiring out of private practice, moving over to be a hospital. And so basically they were looking for a home for these 67 primarily cerebral palsy kids with severe spasticity managed by baclofen pumps. And so, everybody said no. And I was the only sucker that said yes. And I really wondered whether it was a good decision or not at the time. But looking back at it, it's one of the best decisions we've ever made. This patient population is tremendously grateful. They're excellent to work with. They're a lot of fun. And then I had other patients I knew were not being well treated in terms of pain, cancer and severe pain, and very quickly adopted them to pain pumps. Now I've got my guess is maybe 500 pump patients. I've got, they're kind of ongoing right now. About 25% of those, 25% are baclofen, the rest pain. So fast forward a few years and it's mostly pain.
Yeah, that's just fantastic. I think you really outlined some of the reasons why interventional radiologists are really well equipped to
Yep.
learn and implement this therapy. Even, I know there are a lot of interventional radiologists in community practices who are doing high level oncologic care, kind of, everything from the embolizations, ablations to some pain control. This is just seems to be such an obvious thing within the wheelhouse to add to those patients. And so, if we have audience members out there who are interested in getting into this, aside from getting the book, which is great, how can they kind of pursue getting that training?
Yeah, just we're all good communicators. I mean, anybody to reach out to me, I'd be happy to kind of turn them on to the various training courses where you can go to get additional tips, tricks, and experience with this. Be more than happy to do that. And once you kind of get plugged into the space, you see things on social media. Here's a course, here's a topic, a webinar. We're talking about this, about spasticity or trialing doses or things like that. But I really the purpose of the book was to try to get a how-to guide. So if people have questions about it, to take a look for additional experience with this. There's lots of different things that can be done. And I would ask them the community that does this is relatively small. And I think it's one of the most undertreated, underserved areas that we have. But to be able to reach out to people in the community for additional training and experience, be absolutely happy to steer them in the right direction, Jacob.
Fantastic. And speaking of social media, where can our listeners follow you and keep up to date with your latest and greatest pursuits?
Primarily Twitter and LinkedIn. The Twitter handle is at Doug Beall, all one word. Last name is Beall. And then just look up the name on LinkedIn, and the only one, my picture's on there. And I try to post good, informative, educational, sometimes provocative posts. As you'll see, there's not really much I don't shy away from, tend to stretch the boundaries. And, about 4 years ago, I started doing this mainly at the request of some of my colleagues that said if I stepped off a curb and got hit by a bus, a lot of the stuff would go by the wayside. Nobody would ever know it happens. And I have to say, I really was skeptical, highly skeptical. I thought I'd throw some of the stuff out there that I typically post, some of which are familiar, some of which don't even have names to the procedure. Thought I'd get a lot of criticism, feedback, blowback from it. People would be a little bit put off, but I have to say it's been exactly the opposite. Exactly the opposite. I think I've gotten a lot of feedback. Hey, I've thought about doing this, or I have done that a couple of times. What do you think? What's your experience? And it's been a combination of broadening the horizons for me to be able to understand that there's a whole community out there doing new cool things, that I'm not the only one that's a little bit reticent to put a procedure that doesn't really have a name out there on social media, but that's done very commonly in the patient population that doesn't have any other option. Like, a lot of cancer patients, a lot of severe pain patients, non-surgical candidates, or along that category, patients that don't really have an option are looking for novel, innovative solutions. And I can think of a group no better to handle that than the interventional radiologist out there. It's the old shirt that you see at SIR, interventional radiology, inventing procedures for other specialties to steal since 1968. I mean, very, very good innovators. And this is an area that for the social media aspect, I've been very pleased about the response I've gotten from it.
Absolutely. I definitely recommend all our listeners follow. You're going to see some really cool stuff, just really exciting. And so, Dr. Beall, that's all I had to talk about today. I want to thank you for joining me and for the BackTable crew for making this discussion possible. I learned so much. I'm sure our listeners will as well. Any final words before we wrap up?
Yeah, just a shout out to the guys at BackTable. Thank you very much. And Jacob, thank you very much for being such a great host.
My pleasure.
Really appreciate it.
Absolutely happy to do it, and look forward to some future discussions, maybe on some of the topics we briefly touched about a little later on. We want to thank all our listeners for tuning in for this multi-part special with Dr. Beall. Stay tuned for more episodes of BackTable coming soon, including more interventional spine and pain-focused episodes. Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable MSK on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Jacob Fleming, and co-hosts
Michael Barraza
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Junwood Kennebrew.
Thanks again, and see you next time.